yes, recovering.
Very nice. Having
It takes its
positive
own
thought.
course of time, no? So I'll have to bear it.
Thank mind. Then they keep on moving 90 degrees. And
Yeah,
then they
that's true.
Good morning, ma'am. Good morning, ma'am. Good morning, ma'am. Good morning, ma'am.
Good morning. How are you?
Good, ma'am.
So, Binu, when are you going to go to church?
Oh, you are muted. Unmute.
Madam, good morning. Actually, we went to night time. 10:30
Okay.
was the service. We reached by
Oh.
2 a.m.
Okay, okay.
Good morning, ma'am.
Good morning, Jay.
Good morning to all respected members.
And happy Easter and good morning and welcome.
Good morning.
Thank you.
Who's there? I couldn't see actually.
Lavanya ji should be there. Neerja ji should be there. Ashia ji called me. She is not going to be here. Perhaps she
Okay.
told you also her sister is landing and she's at the airport. So flights can be late also.
Yeah, I'm not able to see Lavanya. You said Lavanya is there?
Somebody said good morning, Sai.
I can't see Lavanya. Dr. Khanna, can we start?
Of course, now we should. Okay, Muthuji, next slides.
Yes, ma'am.
This webinar is going to be series number 5. We have our 4 presenters. First portion, I will be doing master ceremony and introducing all the dignitaries. Second portion, master of ceremonies, Dr. Muthu sir, and he has prepared this beautiful, beautiful PPT also. He is a president of Karnataka chapter 15. Next. I will give a brief introduction that I had my doctoral degree from internationally renowned Columbia University in New York after completing initial GNM in Delhi and post-basic BSc nursing in PGI Chandigarh. Have more than 45 plus years of professional experience in a variety of settings such as teaching, administration, research, management, and in 5 different countries. A life member of many national and international societies, had been chapter president of International Nursing Honor Society Overseas Branch, USA and Canada also. That was TNA also, represented in United Nations as a representative for the non-governmental organizations. Published extensively in referred journals and authored one book on perspectives of India and Indian leaders from 47 to 24. We have extended 2 years to have our 3rd edition. Founder and giver patron of CNRS, which is a Clinical Nursing Research Society with headquarters in Mount Abu, Nursing Honor Society with headquarters in Indore, and the Nursing Scholar Society, of course, Dr. Binu Sir in Rajkot, and also patron of National Teachers Association of India. Awarded and felicitated numerous times. Societies actively involved in enhancing the mission of NSS, which is care of the caregiver. Next slide, please. My message is almost same because we are doing the same things each month. Once again, we are here to listen to the valuable researches conducted by our executives as they are part of doctoral studies. I welcome all the dignitaries, presenters, and lovely audience. My message is simple and clear, which is care of the caregiver. Our executives are doing so much hard work for our society and are voluntarily willing to spend time to share with us their scientific research studies, especially findings and implications for our prestigious profession. The series may be continued for a long time as we receive very positive feedback from the younger nurses who get benefited from the findings and try to assimilate in their quality of nursing care. My best wishes to them and God's blessings for a successful session. Next, sir. I will start with introducing our founding president, Professor Dr. Binu Jo. He is a gold medalist and is currently working as principal. He has 16 plus years of professional experience and is actively enhancing our mission. He has conducted many national and international workshops and is a proponent in our successful recent international conference in collaboration with Vibrant College of Nursing in Surat. He has published many research articles in referred journals and has written or authored textbook on pediatric nursing. Sir is lifetime member in many prestigious professional, scientific, and on boards of referred nursing journals. He is pillar of our NSS Society, and I would like to invite Binu Sir to give his valuable message. On to you, sir. Did he step away so we can go to next? He can come back.
Yes, ma'am. Good morning to everyone. Respected dignitaries, all the presenters, dear audience, a warm greetings of the day and namaste to all. I'm very blessed to be part of this with the legends, Dr. Vimla Kapoor ma'am, Dr. Suresh Navlakha ma'am, Neeraja ma'am, So it's a very blessings to hear from you all, and it's always an energy-driven platform of our research webinar series. And I'm very happy to see that all of them are there sharing their research studies and disseminating their findings so that we all budding nurses can enlighten from this great findings of their study. This of course, research is very essential for the advancement of human healthcare, and research plays a very crucial role in improving the lives of humankind as a whole and strives to provide the best quality care. Research helps to enhance our own professional standards. It helps us to provide deep insights and the facts with the proper scientific evidences. And yes, as our scholarly society, Nursing Scholar Society's main mission is also to promote the scholarly activities in the spheres of either in writing, reading, or speak. So for the overall development towards the quality of nursing profession, it's really great moment when our own founder members of the society share their knowledge of research among the fellow professionals. So I'm very thankful and excited to be part of this webinar series of research. Thank you, one and all.
Go through this brochure that we have our history already shared and objectives also, but just to say that Professor Dr. Neerja is our chief guest, and Kuntala ji, and we prepared some of the things in brochure and all. Next. Guest of honor, Professor Dr. Lavanya ji, and she's also a resource person. And guest of honor is Professor Dr. Muthu sir, and he is my master of ceremony for the second portion. Special guest, always so graciously they say, yes, we will join you. And this is such a confidence building when they say yes. Asha ji cannot be with us, but Professor Dr. Bimla Kapoor ji is with us. Then our presenters, just I will say the names and then we'll say about their profiles later. First, our Dr. Mrs. Swati Ompal Patanbal is presenting. Then Mrs. Bimla Devi Kaushal-ji is presenting. Our Professor Dr. Amandeep Bajwa-ji, and Professor Dr. Jaydeep are presenting today. So these are our 4 research presenters. Very, very, with the nursing leadership qualities and skills. And we will hear from them about their findings and implications. Next. Go to next, please. Our today's chief guest is Professor Dr. Neerja Sood-ji. Very pleased to have her here, honored. She is PhD in Public Health specialization Public Health Management, MPH, MA in Public Health Administration, MSc Nursing, BSc Honors, Nursing Postgraduate Diploma in Distance Education and Postgraduate Diploma in Bioethics, completed various online short courses. Foundation for Advancement of International Medical Education and Research, FAMER, and fellow for that since 2014. Professional experience, 40 years in clinical, public health, administration and education, at present working in School of Health Sciences, Indira Gandhi National Open University, since last 60 years. PhD Programs Coordinator, Program and Course Coordinator, and of Diploma in Nursing Management Program. Member of Board of Studies, member of Doctoral Committee, Supervisor, Evaluator, and Examiner for PhD and PhD Supervisor. Can you put it up? Received awards for Best Judge and Reviewer in International Conference in 2015 and 2016. Go to next slide, please.
Yes, ma'am.
Worked in Delhi government DHS for 22 years. First register Delhi Nursing Council. Worked in National Health Programs. Team member for establishment of National Rural Health Mission in Delhi. Honorary nursing consultant to Delhi government. Resource person for planning and organizing. First induction for training of nurses in Delhi government. Resource person for training doctors and nurses in hospitals and the Delhi Directorate and in TNAI, College of Nursing, CNRS, resource person in various projects, member of the 6th and 7th Committee at TNAI. Published papers in international and national journals in nursing, public health, and open distance and online. Blended education. Presented papers in national and international conferences, editor and reviewer in national and international journals in the field of public health and nursing. Member of various professional associations and societies. Chairperson of a research committee, CNRS. President, NSS Delhi Chapter, Lavender Chapter. Received Lifetime Achievement Award from NS in 2021. Go to next. I invite Deejaji for her chief guest message, please, and blessings to the presenters.
Thank you, ma'am. Good morning. Am I audible?
Yes.
Yes, ma'am.
Thank you. Actually, sorry, in between there was some problem. Actually, I was traveling, just reached back. I will share one news with Dr. Vimla Kapoor. Madam, my niece got graduated from IIM Ahmedabad yesterday.
Oh, congratulations. I think all efforts of Neerja and of course your brother and sister-in-law. Congratulations.
Thank you, ma'am.
I'm happy
Because
to see
I
a small
remember
child.
you were the first one with whom I shared this news,
Yes.
and yes, yesterday she is graduated.
I'm very happy. I'm so very happy. Please bless her.
Thank you, ma'am. Thank you so much for your blessings. That's why I was just came back home only just 2 minutes back.
Okay.
Yeah, thank you, ma'am, Dr. Sukhanna, for giving just such a generous introduction. And I would like to say, first of all, congratulations to all the speakers who are going to present their research. It's a forum where I think our younger generation or the upcoming researchers, nurse researchers will learn about various aspects of the research, and how to conduct the research is very important. What are the various aspects and what are the challenges the researchers have faced, so that they learn lessons that these are the challenges they can also face, and they can actually get a guidance also from these researchers. That is the basic aim, what I feel is for this presentation of the research, and they can further take up some of the topics so that they can strengthen the evidence and bringing new knowledge. Actually, what I thought today to speak in brief just about gender inequalities in healthcare and work, because this is a concern of WHO also. And this is a gray area where nurses can do lots of research, not only because there is gender equalities in health and care work, but we ourselves, because nurses still majority, we are from a gender aspects. If we see, it's a female gender oriented profession, and we also need to work on what are the inequalities what nurses even face at their workplace. And I was reading the history of the medical also. There I found even in the medicine, how the women had struggled to come up in the medicine profession also. So I think this is an area of concern. If we see, WHO has published a report that is a fair share for health and care, gender, and the under evaluation of the health and care work. It is a very interesting report. If any one of you are interested to know about the gender inequalities at the health and the care work, this is really a very good study. it actually illustrates how inequalities in health and care work negatively impact the women health system and the health outcomes. It has given various examples. So I think the impact can be studied in the respective state also, so that can be compiled at our country level. We can then find out the solutions. What is the impact of the inequalities on the nursing professionals? Because majority, still 90% are women, and health system, and we are very important part of the health system, and the health outcomes has an impact on that. COVID-19 has brought into focus the critical importance of health and care work. Pandemic also revealed deficiencies in current model of care. COVID-19 signaled an increased reliance on unpaid health and care work, and also like to be performed by the women. Actually, COVID again has taken us back to centuries back, where women were the caregivers. Whenever anyone used to fall sick, women were the first one to take care of the sick in the home. So same, the COVID-19 has brought in the cycle back, that all the burden of the care, irrespective, she's a housewife, working woman, is a professional, women has to take care of the health of the family. And even when they are working, they have to take up that pressure also. Women are the backbone of the health and care economy, comprising nearly 67% of the workforce. Beyond paid work, it is estimated that women perform 76% of the unpaid care activities. So you can see the unpaid care activities which are being performed by the women, it is nearly 76%. So what we can do for this? That is a concern area. So I hope someone will take up this issue. Women tend to be highly representative in the direct contact health and care occupation, such as nursing and various other related associate professions. Improvement in population health can be attributed to women's unrecognized work in the health and care. Evaluation of the health and care has implications on the health and the care of the workforce. Some health and care occupations are treated as an extension of women's domestic unpaid work. They are highly feminized and often imply a lack of social recognition, poor working condition, and low pay. This impacts the value of the health and care sector as a whole. If you see Anganwadi workers, they are underpaid. ASHA, all the community health workers who are working in the community level, they are not being paid at a regular employee. They are being given incentives mostly. So it has impact on their health, working conditions, and their social status of the women. As a highly feminized sector, wage conditions are worse compared to other economic sectors. So this is a grave area, and it's an area of a concern. As a result of pandemic, women caregiver responsibility include unpaid care almost doubled, with the women shoulder more work than the men, and the women is disadvantaged group shouldering more work compared to women in the privileged group. So this WHO report is highlighting that the women in the unprivileged group or who are vulnerable are shouldering more responsibility, and they are not being paid equally. Certain activities such as chronic disease care that were previously taking place in the health services were shifted onto families as unpaid care and largely performed by women, particularly experiencing multiple forms of marginalization without pay or the social protection. What I had just now, I have given you the example. Women across world already facing gender disparities before pandemic experienced increased economic adversities, worsening health conditions, disappropriate responsibilities, and highly gender-based violence. women were more likely to lose employment and forego paid work for others or drop out from the school. The report highlights that women and the girls drop out from the schools because they have to work for the family or take care of the family. So I just thought these are some of the concerns which the young researchers can take up. Why? Still, after independence and so much of advancement, the status of women, the gender inequalities still have not only in the rural areas but also in the urban areas and even in the educated families. Even till today, if girl child is born, there are many issues irrespective of the strata of the people economic status. So I think with these few words, I will like to again congratulate NSS for taking up this research initiative, and congratulations to all the presenters for presenting their study, and hope our young nurses will gain from this and actually will move forward with the new and the recent areas which need to be explored rather than taking up the old areas and developing only uh, packages or other things. So there are unlimited areas where you can do the research. This is WHO report. If you read, you will really an eye-opening report. Please go back and read this report. I hope it will be very beneficial. And I thank Dr. Sue Khanna and Dr. Binu Jo for inviting me as a chief guest for this session. Thank you so much.
Thank you so much for your pulse of wisdom and coming after all that, whatever you did yesterday from Ahmedabad. Thank you again. Now, coming to that, our guest of honors, and before that, I would like to introduce our special guest, Professor Dr. Bimla Kapoorji. She is our senior advisor, National NSS and Iron Lady. Our respected Iron Lady, Professor Dr. Bimla Kapoorji, is our senior national advisor. She has 55 plus years of professional experience in a variety of settings: clinical, education, administration, research, continuing nursing education at national and state level, pioneer in distance education in nursing at national and international level. She is a chairperson of experts in National Nursing Bill Committee with the Ministry of Health and Welfare, Government of India, and bill has passed in both houses. And Madam has published extensively and authored very first book of psychology, and still it is held as a key book to study to gain skills for our quality. What happened?
We can see you.
But there is nothing to say, so I'm going back to.
The PPTs are not there.
Yeah, PPT is not there. So I will continue because I don't want to miss any slide. And yeah, Madam has published extensively and authored very first book of psychology for nurses, and still it is held as a key book to study and gather skills of our quality care of nursing. I will give to Bimla ji for her blessings to our researcher presenters, please.
Thank you very much, Dr. Khanna. It's always pleasure to be present here, as I always say, because you learn in every situation, in every day when you are coming in contact with the scholars in nursing. Dr. Vinu, I think always present, and you are true person who has really led NSS so very well. We have our chief guest. I'm so very happy, Nirja, for the sharing of happy news. And I think I am the first one for her many, many good news. And I mean, I am there for all the best news what she delivers, and I become the first one, and I'm so very proud of it,
Thank
Dr.
you, ma'am.
Manju, also the guest of honors. Looking forward to meet you all when you speak. The research presenters who are coming up with a very important topics. Let me say good morning to each one of you and a very happy Easter. Now, I think it is a pleasure. Why I call it as a pleasure to part of research, because the scholar has done so much of work for 3 years, 4 years, 5 years to really come back with the data, analyze it, and interpret it into the language which we as nurses can understand and implement it in improving the nursing care. It may not be shown as a work of ABC, but when you hear certain outcomes, you try to apply that and see whether you can bring a change in the patient outcome or in the quality of patient care. So that's very significant when we hear the presentations done by you all. The research done by you and then present it to the larger group, because we are able to really incorporate the ideas and see that either we guide our students or we guide our scholars, or we also try to see that we share these experiences, that such and such person has done a study, go back and try to review and incorporate those kind of ideas. So believe me or not, when first series was started, I was thinking, why didn't we do it earlier? But then I always felt it is never late, because whenever we start, it is never late. And it was a really good initiative taken, especially on holidays, Sundays, and I find many people join. So that shows enthusiasm to hear that what is an evidence-based nursing care, which is being followed by doing the research and also implementing the research. Now, I don't say that you need to do in a totality the whole thing, but at least, in your own small way, try to implement the part of those studies and find the result. Most of you are nurse practitioners, I mean, clinical nurses. Most of you may be academicians in nursing or nurse administrators. Try to percolate the findings through your staff nurses and see that whether you can implement that or not. Don't stop it here after the presentation, but see that implementation can be done and also the effectiveness can be assessed. Now, with these small efforts, there will be improvement in the patient care. Let me congratulate each one of you for your continuous efforts and see that you are able to do more research. It may not be a large research of PhD level. It can be a clinical research of how to improve the pain in see that the pain can to talk when the patient is depressed. Small little issues, but we should be able to implement it and see the results. Let me also share with you, our patron has also established Clinical Nursing Research Society in India, and we have signed an MOU with CAHO. So CAHO is looking forward, and CNRS is looking forward for you to come up with a proposal of research studies, which is of a larger interest for the patient care or nursing administration, so that we can also generate the funding from CAHO and also CNRS, and the funding can be done. I thought I must share with you this so that more and more people can take up the research studies other than the PhD to improve the clinical care. Thank you very much. And I look forward to hearing each one of you, wishing you all the very best for your presentation. Thank you.
Thank you for your also wisdom, and we will move from Asha ji. Next slide. She's not here, so next time we will be going through her profile. And now I would like to introduce to you our guest of honor, Professor Dr. Lavanya Nandanji. She is a resource person also today for the presenters. Madam is currently working as director and principal of Nightingale Institute of Nursing in. She has published 20 research articles, authored a book of first aid and cumulative records, and is doing ongoing books editing in nursing research and mental health nursing casebook. She was awarded as best teacher by Parental Institution and accolades by INC, UP government, and UP national something has participated and managed many projects at national and international level, such as Sweden. She is joint secretary of First NSS Chapter Lavender of Delhi and NCR. She is president of INNO Health UP Chapter Nursing Section. She has worked successfully to have her institution as a mentor institution recognized for maintenance remarkable quality of nursing education in Uttar Pradesh. She is life member of ANEI, SOMI, TNAI, NSS, and is our Hall of Famer executive. It is our pleasure to nominate her, and she was, as a Women's Day Achiever and as National President Certificate and a plaque, inviting Madam to say a few words for the students and future leaders. Lavanya ji.
Thank you, ma'am. Thank you so much for this wonderful introduction. And as I always, I mesmerized by hearing you, by seeing you. As I said, you are the great motivation for me. Every time I look up on you for the, take up such a kind of motivation. And pranam to all my gurus over here, Madam Bimla Kapoor, Dr. Nirja Sood ma'am, and all other friends of mine here. Thank you so much for inviting me here, and Dr. Binu, of course, President. And I feel very much honored to be here on this day and this kind of platform on a research activity. I must say that though I'm a very young person to comment on research in India, but I would like to say that I'm part of certain research of ICN, because last year they had invited for the project through WHO. So I had applied and I was, selected for that. And I was personally there in Switzerland, Geneva, in ICN for, having this leadership exchange program for around 10 days. And I was from India. And now the research is on. And the good news is they're funding for this. ICN is funding for this. And this is from CR region. From India, I'm doing. From Nepal, there's one counterpart. And from Myanmar, another counterpart. Through WHO and Indian Nursing Council, we are conducting this survey on a, leadership competency among nurses and midwives in all areas like academia, nursing at the administration level. So what I would like to say, all the budding nurses and the researchers here is, including me, that we are not aware that there are a lot of organizations are willing to fund you if you are really coming up with the burning research area, especially in India, because now we are working on SDGs, as Madam Nirja Sood addressed, that there are many SDGs still we are not addressed to that extent, because 2030 is the, reaching goal. So we can take up small areas, not to be so much ambitious for with a bigger area and coming out with no results. As Madam Bimla Kapoor said, let's take up a fragments of a big problem and work on the research and look forward to the research enthusiasts who can take up this kind of project. And I would like to say that everyone is willing to fund you, like ICMR, WHO, INC, ICN, and also there are some NGOs have come up. And recently I was going through, like Florence Nightingale Foundation from UK, they are inviting for this kind of projects, and they're also funding a good amount for conducting a research in your own country. So I recommend let's be a little more go in depth about these research activities. Let's not wait who will fund. There are many organizations ready to fund you, but only thing is you should be able to take it to that level of research activity and the outcome that matters to everyone when they fund you. So with this note, thank you so much, and congratulations to all the research presenters here. And I must say that it must have gone a long way and also a good depth of work. And your energy must have taken for this research. Let's look forward to have your hearing from you about your research activities and research findings. Thank you so much, ma'am. Thank you, everyone.
Thank you, Professor Lavanyaji. And you will be sticking around because you will be listening and giving your feedback. So good to have you with us.
Thank you.
I will introduce Professor Sarmuthu. He is our guest of honor also and a master of ceremony. Next slide, please. Yes. Sir is president of our NSS Forsythia chapter, number 15 of Karnataka. In addition to doctoral degree, he has MBA also in hospital administration. He worked as NAB consultant and as clinical auditor, and he has certified 10 hospitals for NAB level. He has received many certificates and awards. Training of the trainers taught course in midwifery faculty development program from
Was that on the Papa?
He is a certified internal assessor for Kayakalpa, NQAS, MUSQAN, Lakshya program. He is also certified Lean Six Sigma, Green Belt, Yellow Belt, and Black Belt. I'm scared now. Sir is life member of many nursing associations and societies, such as TNI, QCI, NTAI, NSS, etc. He is a certified master trainer for simulation education from NRSC. He has organized national and international webinar. I invite Muthu sir to continue with the second part of MSc and have the presenters come one by one.
Thank you, ma'am. Thank you for a wonderful introduction of mine, ma'am. Respected Khanna, ma'am, Dr. Benu, sir, President, and Bimla, ma'am, National Advisor, and Dr. Ashia Kuresi, ma'am. Attend today's chief guest, Professor Dr. Nirja Sood, ma'am, President of NSS Delhi chapter, and guest of honor, Professor Dr. Lavanya, ma'am, Nandanji, ma'am, and the eminent speaker of today's events and NSS member of all participants. It's my honor and pleasure to be here as a guest of honor, master of ceremony in this research presentation series. The nursing has a tremendous influence on current and future professional nursing practices, thus rendering it an essential component of the educational process. This research presentation series are providing opportunity to students, clinical nursing personnel, and faculty members and budding nurses to gain knowledge from their nursing leaders and utilize their research findings in the different areas. I would like to thank respected Khanna ma'am for initiating such a wonderful events and providing the platform nursing personnel to disseminate their PhD works with others. I wish all our today's researcher presenter that your productive work will be utilized by the individuals and the society. Now, I would like to introduce our first presenter, Professor Mrs. Swati Patnawala ma'am. Madam is currently working as a professor in Rajkot Medical College of Jalan, and Madam has 13 years of professional experience in a variety of settings. Madam has published her research articles in national and international referred journals and has authored a book of forensic nursing and manual procedures of midwifery. Madam has presented in many conferences at local, state, and national level. And Madam also she has reviewed many nursing textbooks. And Madam research study, practice, policies, and rates of pediatric immunization MP focused on its effective focusing on critical assessment. Madam is also a practical exam as well as a paper setter. Now I invite Madam Professor Swati P. Madam for their significant presentation. Over to you, ma'am. And the title is Practice, Policies and Rates of Pediatric Immunization in Uttar Pradesh and its Effectiveness, a Critical Assessment. Over to you, ma'am.
Good morning. I'm very thankful to give me this opportunity to present my research thesis. I thank to Sui Khanna ma'am for. I'm trying to share my slides, but I am unable. Okay.
Just push their screen.
Okay. Is it visible?
Yes, it came.
Okay. Thank you, ma'am. So,
Sorry, madam, first
yeah.
take full screen and then.
Okay. Okay, so as you seen, the statement is policies and rates of pediatric immunization in Uttar Pradesh, its effectiveness and its critical assessment. So pediatric immunization is due to the medical reasons, and this shows or no correlations between as the Center for the Disease Control and receiving vaccine in India, the rates and the fever and what are the side effects. For this, I took this statement. Some recommendations according to IAP is that hepatitis B vaccine, according to diphtheria, tetanus, and rotavirus vaccine. There are certain changes or certain updates they have given in the polio vaccine, that is IPV should be take OPV as soon as possible in either or optimal choices on primary intramuscular injections also available up to the time of 8 weeks of doses, or instead of this there is a youngster should be taken in practical at least 1 dose of intramuscular available vaccine should be taken. So typhoid vaccine, rabies vaccine, these are the vaccines that are the single dose of it should be given and recommended, and now it is the booster dose of typhoid conjugate vaccine not recommended in the years. So measles and the measles containing vaccines, they are according to 9 months we are giving, but MR vaccine as a part of national campaign is to be admitted irrespective for the previous vaccinations. Primary care provider awareness and practice of childhood immunization. According to WHO, there is million lives annually. Full use of existing vaccine might save 1.7 million. According to WHO expanded role program and immunization for that, regularly 2,000 programs have been held placed to immunization, and 30 lakhs annually getting their extraordinary gains vaccine preventable diseases, and 30 lakhs only permanently disabled. So vaccine is the preventable disease that declining last 2 decades. And
Ma'am, your
Yes.
slides are not moving, please. Your slides are not
Okay.
moving.
Is it net problem?
No, ma'am, please make it full slide.
Okay, is it here? It is
Slideshow.
okay. I have made it. From my side, it is moving.
Oh, because it is on the slide only.
Okay, okay.
Did you push share screen?
Yes, ma'am.
Because this may be from our PPT.
Yeah, now is it fine, ma'am. Now is it fine.
Yeah.
Okay. Okay. So primarily, providers awareness and vaccination is one of the most cost-effective and health promotional. WHO estimate that currently immunization and programs median annually. So 30 lakhs of extraordinary gains and vaccine preventable diseases and another permanently disabled. So vaccines are very important, and high rates of vaccination is needed in infants and preschools in many parts of the world. So 90% of school-age children are immunized, but preventable diseases have fallen by 90% in some level. So variable including socioeconomic status, education of the parents, role of the health professionals, and definitely we are comparing the urban and the rural level health professionals, parents behavior, parents practice, and the health professionals practices. So if we are increasing the efficiency in preventive measures, we have to see aside that there are certain 5-year plans have been given by the government, and National Rural Health Mission also doing such works for the achieving a better use of existing vaccines and preventing diseases, disability, and the deaths. So mortality and morbidity rate also get affected by this certain preventive, affected by this immunization side effects. So better educate the public and members of the health professions on the benefit and risk of the immunization. So our health department having an important responsibility for local health departments for jurisdiction and range government support, and also the financial effort also needed in this expenditures that federal government address the need for powerless communities. However, the states will be. So these are certain literature reviews which I have given in my study. The difficult hack of series of death. United States had 90% pertussis, fertilities, and then their vaccination coverage and influenza. Then These are the certain, so I will not take more time. So my objective of the research is to assess the practice and policies of pediatric immunization in Uttar Pradesh and connection between the practice, policies and frequency. Then adolescents vaccination rates, performance indicates in the also important. Up to 5 years, we are seeing the best vaccination, but after 5, what it is needed. It is also important in now vaccinations, as we have all faced a big danger sign of a coronavirus and we are affected by it. So we have to be updated in the vaccination to describe the durability of medicine used in the kids and explain connection between the guideline rates and evaluate the practice and policies in Uttar Pradesh for the vaccination of children, and to assess how innovate the community building, a certain effect of state apology and identification of the vaccination policy beliefs associated with the practices, the high risk of the low immunization coverage. So scope is all children should have access to comprehensive, including recommended vaccines. Providers should compensate the mandate immunization mandatory are there, public health policies are there, then enhance the disease surveillance and immunization rates. The need of the research, as immunization in the practice more than protecting person, safeguard entire population, morbidity, mortality rate, vaccination, smallpox, and it is very important for the wealthy countries and developing countries. So hypothesis is awareing the child immunization, practice immunization, and secondary is the healthcare providers should recommend to the patient, increase access to vaccine service, and educate the potential vaccine recipients. Limitations are legal restrictions on which provide vaccination serve a jurisdiction, governing with medical person allowed to deliver vaccination, and proper administration of side effects such as dizzying. We have to assess and we have to educate to the person. The data collection I have done by the primary data collection with us directly, we have taken data from the patient, and secondary data collection we have taken from the newspaper analysis interpretation, where the results I found that demographic variable, majority of urban mother were between the ages 25-27, while 12.5 were the 32%, whereas 36.8% rural moms were aged to 28 to 32, and majority in the urban, 33% of postgraduate compared to 45%, and 3% have a tertiary education, whereas 3% are parent having a high school education. In urban region, if you see 74.3% of dads were employed, whereas preponderance of the 42% of fathers were in rural areas were working. So 7% of urban families have monthly family. If we see about the income, that majority of those 62.5% from urban originate from the nuclear parents, and 64% metropolitan areas are also nuclear families, whereas the 62.5% of them lived in the urban area and had 2 kids. So these are all about the demographic variable which are found, and 58% at population. Then health personals, that is broken down by the frequency and proportion. 22% of urban personnel were between age 18 and 43 between 23 to 27. 28% were between 28 to 32. Among the rural areas, if you see 26% were between the age of 22 and 37% between 23 to 27. Percentile about the immunization in several categories. If we see, parents across the urban region have 85% overall education, whereas from urban areas news 81% about the reasons of immunization. Parents from the urban areas knew 65% of diseases that prevented by the vaccination. Health personals demographic broken down frequency and proportion. 22% of urban personnel were between age. So this is all about the age criteria. Age is demographic between in health personals. Among rural employees, you see 26% were between the age of 20 to 22, and 37% is 23 to 27. So next is percentile immunization in the several categories. If you parents across urban region has 35% overall the education when it came to vaccine. Relatively 75% are from the rural location. And parents from the urban areas are the 81% of reasons immunization, whereas parents from the rural news. Parents from urban area knew 65% about the disease that prevented by the vaccination. Moreover, half of parents in rural area, if we see about the knowledge, we can always consider it as the 44.8% in the urban parents have strong knowledge of immunization than in the rural area. 90% of parents in urban area administered vaccine. All children, that is up to 80% in the rural area administered kits of the. So here we can assess that the in urban area 90% and in rural area 80%. So urban area is more strongly giving a administering and following the immunization, and BCG vaccine is administered by children 90%, 97% of the parents and 91 parents in rural areas. So demonstrating the vaccination of professional familiarity and immunization, urban health professionals are more knowledgeable than the rural medicinal practitioners. There are more fluid up to the meaning 86%. If we see reason why, that is 626, and preventive medicine illnesses, you can see 24%. Relative information, both global immunization program, we can see is 80%. And aftercare, how they are follow-up, whether they are taking, is up to 24%.
Sorry for the interruption, ma'am.
Yes,
Sorry for the
ma'am. Yes, sir.
Can you come to the findings, ma'am? I think.
Yes. Okay.
Thank you.
So this is all about the correlation Allen's exactly. If we see the conclusion, that is the Indian government must act decisively, fill up gap, so be agreed by others, strengthening the public sector by indigenous private sector to provide safe and effective vaccine. Wherever unnecessary, provide safe and effective vaccine, and also demonstrate the strains and pathogens. And we have to educate to the parents and UNICEF worldwide vaccination shortage. So prevalence scenario, vice versa, some of the better sanitation and vector control, quarantine, national immunization program availability, make better decision on vaccination. Public Indian government should actively encourage the independent research, cost-effective evaluation, and great national. So all low middle income countries, immunization rapidly maturing. Recommendations, if you see youngsters in the neighborhood, and convenient home options include public health clinic, school-based health clinics, pharmacies, and the removal of financial independent vaccine distribution, diminish the demand of sub-locations. Promote the reform of distribution and payment system that govern acquisition, storage, and administration of vaccine is important, which frequently embedded the physicians. Limitations, legal restrictions on with the administer vaccines, regulating, limiting vaccines, and so these are the references. Thank you, Sui Khanna ma'am, for giving this opportunity, and I would like to thank Bimla Kapoor ma'am, chief guest Nija Sudha ma'am, and sir to give me this opportunity to sit here and give such presentation, and they have given me this important time, and I would really be thankful, ma'am. I will be having same in future. Thank you so much, ma'am.
Thank you, ma'am. Thank you for wonderful presentation, ma'am. Now, I'd like to take feedback from the resource persons. Feedback, ma'am.
Shall
Dr. Nija Sudha, ma'am. Ma'am, please. Lavanya, ma'am, please.
Okay, thank you so much. Thanks, Dr. Swati, for presenting such a wonderful research activity, at least in the state of Uttar Pradesh, because I also work in Uttar Pradesh. I know that we have repeated immunization for twice or thrice in the state, in Gautam Budh Nagar district. The reason behind this is the awareness and also health professionals, the study which you have done there, the knowledge of health professionals and the awareness among the parents. So these are something very, very relevant, because when we went through this kind of immunization there, we could identify that there's a lot of gap between what health professionals are educating and what the parents are understanding. There's a lot of misconceptions, superstitious beliefs, which comes along with the vaccination, immunization in at least in our state, UP. So what I feel is your study is good, the outcome is good. So have you shared these findings with the government of UP? That's very important, because WHO is involved, UNICEF is involved, the government of UP is involved, and
Yes, ma'am.
at the district level, the CMOs are involved. But even then, they have to go with thrice the vaccination, some of the vaccination, including pulse polio. The reason is the cost involved in this immunization and the burden on the health professionals, and also the burden on the diseases the country will face in future. So this is something has to be taken care by the health professionals who are working closely with the population. So if you can share this data with the government, at least maybe the
Yes,
population
ma'am.
may be not a very large population, but at least they can take it as a reference for further, executing their immunization schedule in the state of Uttar Pradesh. But it's a really wonderful study and a very relevant study, I must say,
Yes,
and in the state of Uttar Pradesh. Thank you so much.
yes, ma'am. Thank you, ma'am.
Thank you,
so
ma'am.
much.
Thank you for your feedback, ma'am. Khanna, ma'am, anything? Bimla, ma'am.
I think Lavanya has echoed what I wanted to say, but just wanted to find out what was the sample size. Did I miss it?
200, ma'am.
Oh, 200. Okay. That is 100 from urban and 100 from rural?
Yes, ma'am.
Okay. Thank you so much.
Thank you, ma'am. Khanna, ma'am, anything you want to comment, ma'am?
Will you continue? She presented very well, and the implications and those findings, we should be focusing on that for left to present. Thank you.
Thank you, ma'am.
Thank you, sir. Thank you so much.
Thank you.
I would like to ask a question, ma'am, please.
Yes, please.
Ma'am, in which year this study was conducted? Will you give that idea?
2016-17.
Okay, so that time I hope Mission Indradhanush was not launched.
Yes, ma'am.
Okay, fine. Thank you.
Binu, sir,
One second. Excuse me, 1 second.
Yes, ma'am.
The question asked by you is very important. I think, why don't you replicate this study once more? Maybe through your students and others, and we will have a latest
Yes.
data and
Yes,
all the
ma'am.
points discussed with Lavanya, by Lavanya.
Yes,
Then we will have a recent data.
Yes,
2016 is quite far off,
Yes,
and
ma'am.
now we are in 2024.
Yes,
So
ma'am.
it's better that you kindly, through your master students or through your faculty,
Yes, ma'am.
replicate this study so
Okay,
that
ma'am.
we are able to get the latest data and share with the government.
Yes, ma'am.
Okay.
Definitely I will do, ma'am. Thank you so much,
Thank you.
ma'am. Thank you.
Thank you.
Thank you, ma'am. Binu, sir, PPT, sir. Now I'd like to invite our second presenter, Dr. Bimla Devi Kaushala, ma'am, to introduce herself and continue with the presentation. Over to you, ma'am. Dr. Bimla Devi, ma'am.
Profile. Read your profile first. Do you want me to read?
Yes, ma'am. Please, ma'am.
Okay, madam is currently working head of Department of Psychiatric Nursing in Nursing College in Amritsar. She has many years of professional experience in a teaching 9 years and clinical 28 years. Madam has participated, presented, organized, and conducted many workshops and conferences. She had been resource person, member of many boards of journals, and a seasoned publisher, scientific articles in her own specialty. In her words, we are also committed to teach, educate, and train our young budding nurses for the next generation. She is president of our DISA chapter, and now this is a little mix-up, these two lines, so I will just leave it there. Then we are all sleepy, I think, Easter Sunday. But Muthuji, Invite her. Invite Bimla ji.
Yes, ma'am. The research study, second research study. The second research study is effectiveness of the computer-assisted teaching program regarding smartphone addiction and its health problems in school children and adolescents at selected school of Patiala, Punjab. Over to you, ma'am.
Good morning, ma'am.
Bimla ji,
Good morning, ma'am.
good morning and come on. Yes.
Good morning to all respected members. Here, myself, Vimla Devi. I think my updated room is not displayed, and that was Ma'am Amandeep Vazwa. Myself, Vimla Devi, and currently I am working here, Government College of Nursing, Patiala. I have completed my 40 years in my professional field of nursing, and I am pursuing PhD nursing from Desbrook University, Punjab, and completed my MSc nursing from Baba Frinzi University, Freeport, and post-basic nursing from IGNOU, and have completed my initial GNM from Government College of Nursing at Indira Hospital, Patiala in 1982-84. Now, may I start, ma'am, my presentation? So, thank you, ma'am. My research study was, ma'am, smartphone addiction and its health problem among school children and adolescents. So introduction is technology. As we know that technology is a double-edged sword. So there are so many disadvantages of this usage. One of them is the smartphone. Smartphone has become an essential accessory for almost every person in this modern world. Our smartphone acts as our navigator, personal assistant, and so many other sources of the entertainment. In America and in other countries, people almost spend an average about 5 to 6 hours per day on their smartphone. So COVID-19 pandemic had made it each and every person depend upon the smartphone. So due to lockdown, there are so many additional users became the smartphone user became the accessory. There was only smartphone that the source of information regarding update and their families, near even daily needs availabilities. The user of smartphone was around 36% households in the 2018, but it increases after pandemic up to 75% in 22. There are now approximately 88% average, the highest user in Kerala, that is 97%, including household and rural community in our India. So now about the smartphone addiction. Cell phone addiction consists of 4 main components: obsessive phone use behaviors, such as repetitive checking for messages or updates, tolerance, or we can say the longer or more intense of use, then withdrawal, or feeling of agitation or suffering without the phone, and functional impairment or interference with other life activities and face-to-face social relationship. Smartphone addiction is defined as a lack of control to use the smartphone despite adverse effects, including financial, psychological, and physical, social harmful consequences on users. Smartphone addiction is as the same as drug addiction and can be diagnosed by 4 properties: compulsion, functional impairment, tolerance, and withdrawal. So need for study was, there are so many harmful effects on health of smartphone users. Adolescents are the vulnerable group for any type of addiction, including smartphone addiction. There are 75% adolescents using smartphone even more than 5 hours per day. Additionally to the adolescent, other risk factors for cell phone addictions include smartphone users are suffering from anxiety, depression, angry, low self-esteem, mostly are usually introverted in social situations, indisciplined, and poor self-control. Because of the increasing prevalence of using modern technology, there is a need to focus on the impact of smartphone on health among school children and adolescents, quantify severity, and develop proper coping methods to deal with depressive, negative emotions, and behavioral disorder of smartphone addiction. Problem statement was effectiveness of computer-assisted teaching program regarding smartphone addiction and its health problem among school children and adolescents in selected schools at Patiala, Punjab. Aim of study was the current study was aimed to assess and update the knowledge regarding smartphone addiction and its health problem among school children and adolescents. Moreover, the result of this study will assist the school children and adolescents in picking out the appropriate methods to intervene effectively those who are suffering from the smartphone addiction. Objective of this study was to assess the pre-test knowledge regarding smartphone addiction and its health problem among school children and adolescents of experimental and control group at selected schools of Patiala to assess the prevalence of smartphone addiction, to conduct the computer-assisted teaching program, to assess the post-test knowledge, to find the difference between post-test knowledge to find the association of post-test knowledge regarding smartphone addiction with the demographic variable, to determine the correlation between knowledge score regarding smartphone addiction and its health problem with the prevalence of smartphone addiction and its and the experimental group of selected schools at Patiala. Research hypothesis was all hypothesis was tested at the 0.05 level of significance. Hypothesis was there is a significant difference in the knowledge score regarding smartphone addiction and its health problem among school children and adolescents of experimental and group control group at selected school of Patiala. There is a significant association of post-test knowledge score regarding smartphone addiction and its health problem among school children and adolescents with the demographic variables. There is a significant prevalence of smartphone addiction and its health problem among school children and adolescents. There is a correlation between knowledge score regarding smartphone addiction and its health problem with smartphone addiction and its health problem among school children. So, null hypothesis was there is no significant difference, there is no significant association, there is no significant prevalence of smartphone addiction, and there is no correlation between the knowledge score regarding smartphone addiction and the smartphone addiction prevalence. So, methodology used in this study was research design was an experimental study, pre-test, post-test. Research design was used to accomplish the objectives of study. Area of study was the selected research topic was the part of pediatrics. So the schools was selected as an area. Target population was school children and adolescents. Accessible population was school children and adolescents at selected school. Sample technique was randomized, proportional stratified sampling technique was used. Sample size was 20 in each strata, 20 for each gender, that is 40 in each class from 5 classes, that was 6th, 7th, 8th, 9th, and 10th. The total sample size was 200 from the experimental as well as the control group. So variable in that study was the independent variable was the computer system teaching program. Dependent variable was the knowledge regarding smartphone addiction and its health problem. Extraneous variable, demographic variable as listed. Exclusion criteria was the school children and adolescents, those who are not present and not willing for that study. Selection and development of tool. The tool was developed on the basis of literature review and personal experience of the investigator in the pediatric and school children behavior. The part one was the self-structured demographic questionnaire. That is the age, class or grade, parental education, parental occupation, area of residence, family income, and source of income. The second part was structured questionnaire regarding smartphone addiction and its health problem. That was the get validated with the experts in the concerned department. The third part was the use the SAS scale, standard addiction scale 33, to assess the prevalence of the smartphone addiction. The reliability and validity, the tool was got validated from the experts expert opinion from in the pediatric department, community department, and the psychiatric, medical, and nursing. The tool had got tested reliability with the result of pilot study. That was the reliability was the 0.742. SAS was standard scale that was open access was used. Ethical consideration after approval of study and submission of synopsis and ethical clearance from the Deshbhakt University. Permission has been taken from the BEO Patiala and the principal of the concerned schools. Analysis and interpretation, there were the descriptive statistics used, frequency, percentage, and distribution. Mean, percentage, paired and unpaired t-test were used, and the chi-square were used for the.
Ma'am,
to
sorry
get
for the
the
interruption, ma'am.
Ji?
Sorry for the interruption, ma'am.
Ji, sir.
Next, can you go for objective, ma'am?
Object. Yes, sir. Sir, objective of my study was
sorry,
to.
outcome, ma'am.
Outcome. Okay, sir. Sir, yeah, I was saying that. That is the homogeneity tests for both groups that was not significant in all of the demographic areas. So Meyer in the knowledge score was, there was pre-experimental and pre-control group. Adequate knowledge was 0% in both groups. Moderate was 33% in the pre-experimental and pre-control group. That the inadequate knowledge were the 16.7 in the pre-experimental and the same in was the experimental group. Pre-test score of both group was this shown in this graph, and the criteria in the post-test knowledge, sir, adequate knowledge was 79% in post-experimental, 0% as the pre-test in the post-control group. Moderate was 121, 60.5% in the post-experimental and 34, that is 17% in the post-control group. There was inadequate knowledge 0% in the post-experimental group and 83% inadequate knowledge was there in the post-control group. Post-test score of the both groups shown in this graph and the post-test difference in the both group knowledge score was experimental, post-experimental mean score was 19.73, where in the control group that was 8.27. The SD was 2.334, where in the control 2.243. The median score was 20 in the experimental group and that was 8 in the control, maximum 25 in the experimental and 13 was there in the control. Minimum score was the 13 in the post-experimental and only 4 was there in the control group. The range of the knowledge score was 12 in the experimental group and only 9 was there in the control group. So mean value was 65.75% in the post-experimental and only 27.55% was there in the control group, sir. And that is the descriptive statistics score of both groups. And sir, my knowledge score of the pre-test and post-test knowledge score. The pre-experimental was adequate score was 0, where pre-control was 0, but in the post-experimental score was thus 39.5%. That was total subject of 79. And post-control, there was 0 subject with the 0% with the adequate knowledge. And moderate knowledge, that score was 11 to 20. That was the 33 in the pre-experimental. And pre-control was also 33, that was 16.5% only. But in the post-experimental group, 121 subjects, that is 60.5 subjects, had the moderate knowledge score, followed by the 34%, that is 70% only in the post-control group, where inadequate knowledge was pre-experimental was 167, that was 83.5%, and same in the pre-control group. But post-control group, post-experimental group, there was no inadequate knowledge. Whether the post-control group had the 166 subjects, that was 83% have the inadequate knowledge regarding smartphone addiction and its health problem. So that is the criteria. Knowledge score pre-test, post-test with the pair t-test. And the pair t-test value was the 0.295, that 50.072 at the p-value of 0.001, that is significant. Effectiveness of intervention. So experimental group had the post-test knowledge increased up to the 19.73, where in the control group there is only 2.344. Next is smartphone addiction and health problem score. There is the smartphone addiction experimental high score, that was the from 144 to 198. The total score was 198 in the 33 into 6. That was the 198. So high score, that is 144 to 198. Experimental group was the 20%. 40 subjects were there. In the control group, that was only the 1%. The average score was, that is 89 to 143. The 68 subjects, that is the 34%. And the 31% in the control group. The low score was the 33 to 80%, that was 92 subjects, that is 46% in the experimental group, and 136, that is 68% in the control group. So that is the addiction score in area wise, that is the 6 areas. In the smartphone addiction, the daily use disturbance, positive anticipation, withdrawal, cyberspace oriented relationship, overuse, and tolerance. Smartphone addiction, experimental group, and in the control group, that is the area was graph shown in this graph in the different areas. So there is the correlation between the knowledge score and the smartphone addiction, and between the pre-test and post-test knowledge, that is significant in both areas. Thank you very much. Thank you, sir. Thank you to all respected dignitaries and members to providing me a so valuable time and valuable and a great platform. Thank you very much.
Madam, thank you for your wonderful session, ma'am. And now I would like to take a feedback from the resource person.
May I, Dr. Muthu?
Yeah, ma'am, please, ma'am.
Thank you. Thank you. Madam Bimla Devi, ma'am, thank you for the research presentation. I have few queries here. Your independent variable is computer-assisted teaching.
Yes, ma'am.
How did you use this? What did you do here? Because your dependent variable is smartphone addiction. So I didn't connect. Yeah.
Knowledge regarding smartphone addiction.
No, you used a computer-assisted teaching program as your independent variable, right? You're saying effectiveness of computer-assisted teaching program. So, like, what is the relation between this computer-assisted teaching program and smartphone addiction?
Ma'am, smartphone addiction and its health problem was my topic, and I have prepared the PPTs with the this lesson and get it valid from my experts, and then conducted a teaching session with the whole classes at the both schools for the both group, the experimental and the control group, ma'am.
Okay, but unlikely, even computer-assisted teaching program also, they need to use their smartphones to listen to this computer-assisted teaching program unless they're not present in the classroom, if they're in the distance.
No, ma'am, I displayed on the TV, the smart TVs was there in the every classroom in that school.
Okay, you are using computer-assisted teaching
yes,
program.
Yes, ma'am. I displayed with my laptop on the TV screen, ma'am.
Okay, contradictory to your study, ma'am, state of Uttar Pradesh, you know, they are distributing smartphones to all the students. I have 600 students.
No,
I got a Samsung Android phone. It cost about 22,000 per student. You know, recently we have distributed that phone to 600 students.
No,
I mean,
my study was
every-
only to avoid and to prevent and to control the use of smartphone. ma'am.
everyone is encouraging, the distance learning. Like even we are in the same platform now. Many of us are using smartphones, even though we know there's a lot of, hazards, health intervention issues, but still we have to go with this
Yeah, we are
technology.
going to yes, ma'am. So, ma'am, it is in the practice we see in the practice in all area of teaching as well as in the society and even in the families. We see there are a matlab, huge change and the drafting change in the behavior of the docent and school children. They are very addicted to the smartphone, and that's why I selected that topic to assess the smartphone addiction as well as
Digitalization.
I think if the school children and docent know the matlab smartphone addiction and its health problem, they may control their self and can modify their behavior. They use the smartphone, but along with they can use the meaning exercises and this outdoor games and the other modification techniques to avoid this addiction.
I feel a lot of studies should be taken at the primary level itself. When children are very small, we engage them in their smartphones, even for eating food, to divert them. That is the beginning where we need to have start studies regarding this to the parents who are rearing a children and in the schools. Because now there's always activities going on the books now, like more of reading books for the youngsters. Like there's an initiative come up with the book exchange, book reading fair, all these things. I think that kind of diversional activities and also studies which can come up can help out children from the youth itself, because social media is so important now for the youth. They will not be able to survive without smartphones. Not only they, even we can't survive without smartphones. I think at least every minute I check my phone. Even you may check your phone. So it's something, hazard.
Just we can say everybody is in addiction, not only the school children and docent,
Yes.
but we need to improve and modify their behavior because they lose a lot of things. They lose the interaction and the social relationship, even the daily activity and they indulge themselves like a addiction, like a drug addiction. So there are so many other physical. I showed the in my teaching the meaning side effects and health problems like brain tumor and blindness and the other joint pain and the other physical problems as well as the psychological and even some of them getting the at wide range of the meaning high rate of the addiction. They are going to behavioral change like suicide thoughts, ma'am. So that many of the studies in the literature review I reviewed the such studies. So many students are get irritated, anxiety, and behavioral disorders due to the smartphone addiction. That's why I have selected that topic, ma'am. जी, ma'am.
Okay, ma'am. Thank you so much. I think many studies can be taken up. Small studies, fragment करके भी ले सकते हैं. Like social interaction is something really has gone missing nowadays. That is the reason many children are facing even mental health issues because of these addictions. Because they're not in interaction with any human beings. They're only interacting with the gadgets. Thank you so much.
Thank you, Lavanya ma'am. Dr. Medla Kapoor ma'am, anything you want to comment, ma'am?
Just one comment I want to do is that every technology abuse or any kind of abuse is preventable, and also it can be controlled, but depends upon at what stage and who are the people who are helping them to control those habits. More than parents, I think the teachers play a very important role, and probably we have to educate the teachers how to help the children. No teachers in some of the schools in Delhi are allowed to use their phone from morning till the end, except in the recess period. So nobody calls from home unless it is an emergency, and they can only check in the recess period. So there are ways to control. Only thing I was thinking, Bimla ji, your sample size seems to be a small one, maybe because you had a experimental study. That could be the reason, but a sample size can be improved. But yes, there are inbuilt mechanism by which we can manage our children. Also, we can manage, teachers can manage the students, because that plays a very important role. With this, I think let's go to the next study. Congratulations, Bimla, for doing such a wonderful study.
Thank you, ma'am. Thank you, ma'am. So,
Wonderful, wonderful.
Thank you, ma'am. Thank you so much, ma'am.
Thank you.
Channa, ma'am, anything you want to add?
No, you continue and please emphasize that you skip those methodology and stuff and go on findings and implications more, please.
Yes, ma'am. Thank you. Now, I would like to introduce our third research presenter, Professor Dr. Amandeep Bajwa, ma'am. Madam is currently working as a professor HOD of psychiatry nursing in Nursing College of Amritsar, Punjab State. And Madam has many years of professional experience in a variety of settings. And Madam has participated, presented, organized, and conducted many workshops and conferences. And Madam has been a resource person, member of many boards of journals, and publishes many scientific articles in her own specialty. And the next slide, sir. And Madam is a sir, previous slide, sir, please.
Okay, I will read. In her words
Yes.
now, correct. We are also committed to teach, educate, and train our young budding nurses for the next generation. She is president of our DISA chapter number 11 of Punjab. I invite Professor Dr. Bajwaji for her research presentation. On to you, madam.
Good morning, ma'am.
Good morning.
Very warm good morning to all the dignitaries. It's giving me chance to present my research study.
Yes, you're audible, but put that PPT on.
Ji, ma'am, please. One second, ma'am.
Yeah.
Am I audible?
Yes, it hasn't come yet on the screen.
Hangover.
Did you put share
My
screen?
system is hanged. Trying to. और आप भी नहीं बुलाएंगे. Hangover. बस अब शेयर करके देखते करने में.
Can you just start reading them?
I'm trying.
just say at least start reading.
Ma'am, can we go with the next presenter? Till then, Madam Amandeep can get ready with the presentation. Is that okay?
Yeah, we can go to the next.
I'm ready. I can.
Amandeep, beta, can we go to the next? Next slide, please. Okay, introduction of Muthuji.
Yes, ma'am.
Oh, okay. Should I read? Introduction of Professor Dr. Jayadeepa. Madam is currently working as principal at IQ City Institute of Nursing Science, Durgapur, West Bengal. Madam has completed her MSc Nursing, PhD Nursing, MBA, PG, Postgraduate DHN, Certificate Course, Forensic Nursing, Forensic Chemistry and Toxicology, Certificate Course in Forensic Psychology, Course in Victimology and Criminology, Health Research Fundamentals, Research Methodology, Statistics. Indo-American Fellowship in Evidence-Based Practice, ongoing. Postdoctoral Fellowship in Nursing Research, ongoing. Total years experience 22. Author of textbook of Critical Care Nursing by CCN Publication. Written a chapter on social control in the textbook titled Applied Sociology, published by International Publications, and written a chapter on food preservation in the textbook titled Applied Nutrition and Dietetics, published by Navi International Publications. Written a chapter on prevention of needle stick injury in the textbook titled Textbook of Administration of Medication, published internationally. Next slide, please. Next slide. Member in Sigma Theta Tau International Honor Society of Nursing. Member in International Network of Doctoral Education since 2019, and a life member in TNAI, and a national president for Indo-Pacific Academy of Forensic Nursing Science, life member, and Oncology or Research Society, NTAI, and the president of Association of Nurse Executive, ANEI, NSS, and the International Journal of Nursing Education. She is a member of all these editorial boards: International Journal of Medical Surgical Nursing, Journal of Nursing Care, International Journal of Geriatrics, International Journal of Evidence-Based Nursing since 2017. And if there is any more, just give me another slide. Okay, then we are coming to inviting Dr. Jayadeepa ji, and her statement is correlation between self-care, efficacy and quality, BOF life of type 2 diabetic electricity in Durgapur. Jayadeepa ji, on to you, please.
A very good morning to all the dignitaries joined through this forum. Khanna ma'am, thank you so much for giving me this opportunity. And actually, I am going to present my PhD research work only. This is a very old research study, I should say, because I have completed my PhD long back. This data collection was done in 2013 and 14, I think. It's nearly 10 years. I extend a warm greetings from my institution, IQCT Institute of Nursing Sciences, Durgapur, West Bengal. And this was my study, a study to evaluate the effectiveness of diabetic self-management training program on physiological, psychosocial, economic parameters and self-care of diabetics in selected settings. So this was the study I did for my PhD. So this, into introduction, I have discussed these things in my chapter 1, impact of diabetes, diabetes and cognition, diabetes and quality of life, diabetes and cost, diabetes and lifestyle, diabetes and self-care, need for the study. So diabetes is a very old disease, we all know, but still there are so much to learn from it. How much ever research studies are conducted, there is always gap in diabetes care. We are unable to fill this gap, and day by day, the incidence and prevalence of diabetes is increasing only. Maybe looking a very easy, simple thing, but living with diabetes is that much tough. Everyone who is living with diabetes very well understand how difficult it is. And it is a burden of the disease. I'm not going much into this introductory part. Everything we know, diabetes has its impact on cognition, quality of life, and cost of care also. It is not affordable by every class of the society. Some days diabetes was called as a disease of rich people, but everybody is getting now. It is a common and a costly disorder. It is an economical crisis to the individual, family, and country. And if not treating there is always a saying, not treating diabetes is costlier than treating diabetes. If not treated properly, if people end up with complications, the cost of care is always high. Definitely, it is a lifestyle disorder. Lifestyle modifications are required. And especially all chronic disorders, if we see, self-care plays a major part. Diabetes is one of the most important diseases where more concentration on self-care is required, because day by day they have to take decisions regarding their diet, what to eat, what not to eat, how to manage, how to check, when to go for checkup, how to take the medicines, when they are on insulin, how to administer insulin. So there are so much need for self-care knowledge. So once diabetes was considered as a disorder of richer people, but now it has spread all its roots. WHO theme of World Health Day 2016 was Halt the Rise, Beat Diabetes. Individuals undergo series of psychosocial changes immediately after the diagnosis. It is because they have to adapt a new lifestyle in the rest of their life. So self-care is one of the cost-effective measure to lead happy life even with diabetes. Psychosocial disturbances may not allow the diabetics to make necessary changes in the lifestyle. Chronic nature of the disease also contributes to the poor self-care. Diabetics need to be trained on adapting self-care in daily life for better glycemic control, improved psychosocial status, and to prevent complications. So there are very less number of studies conducted in this topic. National studies in the selected topic were very less. So they were also descriptive studies only. During the data collection also, it was noticed that none of the participants attended a training program like this. In India, people are loaded with information, but they do not aware which are right and which are wrong, and the practice is not satisfactory. Hence, the study was needed to make them aware of it. The statement of the problem is a study to evaluate the effectiveness of diabetic self-management training program on physiological, psychosocial, economic parameters and self-care of diabetics in a selected setting. So these are my objectives, hypothesis, and I have adapted Oram self-care deficit theory as a conceptual framework in my study. I have obtained ethical permission. This is where my review of literature. Altogether, I have reviewed 107 articles, all of national and international studies, and the sub-classification is given in a table. And methodology, it was a true experimental design. The settings were COVID Diabetic Specialty Center Hospital and Karuna Medical College Hospital. Sample size was 400. Sampling technique, individuals who fulfill the inclusion and exclusion criteria were selected. So these are all my criteria for sample selection. The tools used to collect data, it had these many sections. 2A was a demographic profile. B was physiological measurements that included height, weight, BMI, blood pressure, PPBS, FBS, HbA1c, and total cholesterol. And section C was self-care activity questionnaire by Glasgow and Tubert. It is a standardized tool. And well-being was assessed by using WHO well-being index. Quality of life of diabetic Indian diabetics were used to assess the quality of life. Diabetic depression scale was used. And there was a tool which is prepared by me, was used to assess the cost of diabetic care. And the training program was the intervention, my independent variable. This was a 2 hours duration training program. The contents included in the program were diabetes and blood sugar regulation, concept of self-management, dietary management, exercise and food care, prevention and management of hypo and hyperglycemia, prevention of complications, care of vital organs, medications, measures to promote mental health, role of lifestyle modifications and how to make healthier decisions, cost of treatment and the ways to reduce it. So these are all the components which were included. And data collection was done through the questionnaire technique. Descriptive and inferential statistics techniques were used to analyze the data. I have used percentage analysis, chi-square test, PETI test, and PETI test, coefficient of correlation, ANOVA, Kruskal-Wallis test, Mann-Whitney rank sum test. Pilot study was conducted. Pilot study was feasible. Proceeded with main study. These are all pilot study report. The results of pilot study shows that the intervention was effective in bringing down physiological parameters to normal level, promotion of psychosocial parameters, and also in promotion of self-care. The intervention was effective in bringing down the indirect cost of care. Tools and techniques were found appropriate and feasible to conduct the main study. As per experts' opinion, it was decided to conduct 2 post-its for the main study. So this is the main study results. The results were classified into 2 categories. Effectiveness of self-care training program on physiological variables as a first part. Here, the frequency distribution of samples on the physiological parameters were placed in a table. Weight, BMI, systolic BP, diastolic BP, fasting blood sugar, postprandial blood sugar, HbA1c, cholesterol level. So this is a frequency distribution of samples. And the intervention's effectiveness on these variables were assessed and placed in a table. On weight, in control group, there is no change between pre-post tests, whereas in experimental group, there is a significant difference noticed. In BMI also, the same results. Regarding systolic BP, in experimental group, there was changes noticed. Now, whereas in control, there is no change. In postprandial and fasting blood sugar level, in both the groups, there were difference noticed between pre-test and post-test, but the intensity of difference in experimental group were high. In HbA1c also the same result, whereas in cholesterol, the difference was high in the experimental group. And regarding the correlation, there was a weak correlation identified between self-care and the selected physiological variables. So this is the graph presented. And self-management training was effective in maintaining physiological parameters within a normal limits. There was no difference noticed in the weight and BMI and blood pressure. There was a very weak correlation identified between self-care and the selected physiological parameters. And there was no significant difference in the physiological parameters were observed between the 2 centers. And the second part of the data analysis, effect of self-management training on psychosocial, economic parameters and self-care of diabetics. Here also the same things are followed. Only the non-parametric tests are used here. So if we see this is a frequency distribution of psychosocial parameters, well-being, depression, quality of life, and the cost of care and self-care. And this is an effectiveness of the intervention on, if we see there is a well-being, there is an improvement in experimental group when compared with control group. Similar results are found in depression also. Quality of life also, there is a difference. Regarding cost, there is no change in direct cost observed in both the groups, whereas in the experimental group, there is a difference in indirect cost observed. Like direct cost, I have included whatever they spend for medicines, doctor fees, all these things. But indirect cost is the transportation to the hospital, leave taken because of illness. So these things are calculated as indirect costs. So that shows a difference in. And regarding self-care management, self-care also is assessed before and after intervention. In the experimental group, there is a difference found. And the domains in self-care, domain-wise assessment also done. Diet, exercise, monitoring, and medications. So in that also, there is a significant difference noticed in the experimental group. And correlation between self-care and other psychosocial economic parameters were done. There was mild, weak correlations found between self-care and well-being, depression, and quality of life. So these are all the same things put on the graph. Self-management training was effective in promoting well-being and quality of life and self-care also. It was effective in reducing depression. The intervention was effective in reducing the indirect cost. There was no change noticed in the direct cost. There was a correlation observed between self-care and the selected psychosocial and economic parameters. There was a significant difference noticed in the well-being, depression, quality of life, and self-care between the two centers. There was no significant difference noticed in the cost of care between two centers. And this is the descriptive information of the demographic variables of the samples. And there was a significant association noticed between the demographic variables with selected physiological, psychosocial, economic parameters and self-care. And to summarize, it was felt that there is an urgent need to meet the needs of diabetics since the prevalence and the complication rates are growing. Available literature also supports that there is a need for self-management training for diabetics. The study was conducted as per planned methodology. It was observed that the training was effective in maintaining physiological parameters within a normal level. It was also effective in promoting the well-being, quality of life, and self-care. It was effective in reducing depression and indirect cost. Within the training, individuals will gain confidence in managing the disorder. Ultimately, it will make the individuals to lead a happy life even with diabetes. Suggestions: healthcare professionals to be sensitized on the self-management aspects of diabetics. Diabetics to be monitored that they receive only the right information from the right source. Hence, the present study proved that there is no difference noticed between the selected centers on the psychosocial aspects and economical aspects, but there are differences in the psychosocial aspects. So there should be an uniform region-wise curriculum which has to be adapted all healthcare institutions for primary and tertiary level, because India is a country with multiple culture, multiple food habits, multiple lifestyles. So I suggest through my study, there must be standardized region-wise self-care management curriculum. Every institution must have it, and that is to be standardized. So whoever people will change, people will come and go, but those who are accessing the healthcare facility are the same and their culture is same. So this is how every institution should have their own standardized diabetic self-management manual, and that is to be taught to them, and that they should be reinforced, and monitoring also is required. Healthy lifestyle to be incorporated from childhood. Self-management module to be included in the curriculum of all and UG and PG students and other allied courses. The concept of self-management shall be applied to other chronic illness also. A cost-benefit analysis to prove that self-management training is a cost-effective intervention in the management of diabetics also can be done. Actually, this was my initial aim, to do a cost-benefit analysis of self-management training only. But that required so much time. Already there were so many variables. It was a very big study. I could not do it. But anyhow, it is always in my plan. I will do cost-benefit analysis of diabetic self-management training. That will be my, most probably that will be my postdoctoral work. To conclude, self-management is a holistic concept. The concepts included in the definition of health by WHO are given importance here. Hence, it can be said that self-management training is a cost-effective intervention in the management of diabetes. So living with diabetes is like living with a tiger. If you feed it, groom it, never turn your back on it, you can live with a tiger. If you neglect it, it will pounce on you, rip you to shreds. So let us educate to all diabetics. Thank you. Thank you for the opportunity given.
Wonderful, wonderful. let us ask our Lavanya ji, resource person. Lavanya ji?
Yes, ma'am. I'm here. Thank you so much. That last quote is wonderful, very meaningful. It sounds the whole study what you have done. I could see, Jaideepa ma'am, your passion for research and what you want to bring out. Means it's definitely a depth study. Though it's part of your PhD, but you have a passion for this topic because you're telling you want to go with the next cost effectiveness analysis for this. But this is area 2013, you've done a study. I think the burden has increased now. It's even more increased.
Yes.
And now there's a lot of changes have come in curriculum also. And when we look at the hospital end, like clinical practice end, there are a lot of diabetic nurse educators have arisen. They have taken the role and a special package for them. So this is something good enough to know. But as you said, it's a lifestyle management. This is something willingness of the population to control this disease. The regional package, what you said, that really sounds good because never the food habits goes with one region to other region. That can be another study can be taken up. I really loved your study, the way you're conducted, and I appreciate it. And thank you so much for sharing the study here. Thank you.
Thank you. Thank you so much.
Bimla ji is there. Dr. Bimla ji, would
I
you
think
like to?
it's a study which continues reinforcement every now and then because it's a lifestyle disease. Your work will never end. It will keep on
Yes.
improving. It will keep on increasing. All the very best.
Thank you, ma'am. That's why I started another data collection here. Actually, this was done with self-care and other impact. Now I wanted to assess the self-care
Good. Very good.
efficacy. How much talents, how much self-care capacity they have and its impact on. That is my independent research work that is completed. I may present it later on some other occasion also.
Okay,
Sure,
thank you,
sure.
Lavanya. Thank you, Bimla ji. And now I will ask Bajwa madam if she's still there
Okay.
to try.
Yeah, ma'am, I have one doubt. Shall I?
Yes,
Oh,
sir.
yes.
Yeah, ma'am, whatever the diagnosis you did means that testing, blood testing and that everything. You means you bear the cost or whether it was a ready-made report from the patient itself?
No, the cost was borne by me only. I have spent so much for my PhD.
That's one of the wonderful aspects, which means you are investing yourself for your study. That's one of the
Since
most
it was
important
done in a medical college hospital, one center, no, they gave me some concession. 50% concession was given. Through that, I
Yeah.
could manage. But the other center, and mostly this fasting and PPBS, it is a routine checkup.
Yeah,
They do
correct.
on there. Other than that, HbA1c and cholesterol, it was done from my packet only.
Yeah, along with that, ma'am, one of your recommendation was there, diabetic care should be a part of nursing curriculum. So from this new INC syllabus, they have made one of the elective module in
Yes,
that.
yes,
I
it
hope
is
you
there.
may be
Now it
aware.
is there. Yes.
So your one of the recommendation is already accepted, and
Yeah,
Bimla
yeah.
Kapoor ma'am was there. So that's one of the wonderful thing. And along with that, with your last slide, which I observed, whatever your two publication was there, that was it was an index journal because very rarely
Yeah.
people are referring that Scopus journal. So I have observed both of your publication was in very wonderful research paper. That's
I have 4
that's one of the,
citations for that study. And
yeah,
that
that's
it
one of
got
the good thing.
200 reads
Oh, wonderful, ma'am.
in
Wonderful.
ResearchGate.
Thank you. Yeah, thank you, everyone. Please, thank you.
Move on to Bajwa ji, madam.
Ji ma'am, sorry for inconvenience. So can I start?
Yes, please do.
Okay. So health is the most important asset of human beings. Today, health has a holistic backdrop and is based on the physical, social, spiritual, and psychological well-being. So the main focus of today's healthcare is on preventive and promotive aspect rather than on curative and treatment aspects. So the term quality of life and more specifically health-related quality of life is coined by the World Health Organization. So the World Health Organization defined the quality of life as an individual's perception of his or her position in life in the context of the culture and value system in which he or she lives and in relation to his or her goals, expectations, standards, and concerns. So stress is an everyday fact of life. It's global and today it exists as a pandemic. So this stressful life is directly affecting a common person, or a common man is suffering from various psychophysiological disorders. So one of the physiological disorder is hypertension, so which affect the lifestyle. So it is a major public health problem. It's a modern epidemic. So in order to manage hypertension, lifestyle management, one of which is yoga lifestyle. So it helps treat and prevent hypertension through mind and body activities. So yoga and ancient but perfect science deal with the evolution of humanity. So it's the science of life and the art of living. So it is the common sense answer to the overall physical and mental fitness. So need for the study. So cardiovascular disease is the leading cause of death in the world. So hypertension is usually regarded as a sleeping snake, so which bite when it wakes up. So the disease, as long as it's sleeping, will not bother the individual, but when it wake up, it bites with all strength, leaving the person with serious disabilities, death, and catastrophic and results. So an estimated 1.2 billion adults aged 30 to 79 years worldwide have hypertension. So most, the two-thirds living in low and middle income countries. So it is the latest data in 2023. So an estimated 46% of the adults with hypertension are unaware that they have the condition. So less than half of adults, 42% with hypertension are diagnosed and treated. So other remain untreated. So approximately 1 in 5 adults, 21% with hypertension have it under control. So hypertension is a major cause of premature death worldwide. So one of the global targets for non-communicable disease is to reduce the prevalence of hypertension by 33% between 2010 and 2030. So So stress is one of the factors that cause hypertension. So there are evidences revealing that stress play an important role in raising high blood pressure. So regular yoga may reduce the stress hormone aldosterone, so which is a potent vasoconstrictor. So yogic practices bring balance at physical, mental, emotional, and intellectual level. So regular practice of yoga can reduce the blood pressure. So it is evident by the study that done by Dr. Sujit Chandra. So during the statement of the study, so an interventional study to assess the impact of yoga therapy on blood pressure, stress, and quality of life of hypertensive clients in Urban Health Center of Shri Guru Ram Das Hospital, Amritsar. Okay. So objective of my study to identify the hypertensive clients in the selected urban health care of the SGID Hospital Amritsar to develop a protocol for yoga interventional therapy, to modify and translate a standardized tool for assessing stress and quality of life of hypertensive client into Punjabi, and to develop blood pressure recording performance, to check validity and reliability of the developed modified tools, to assess blood pressure, stress, and health-related quality of life of experimental and control groups during pre and post intervention period. So to implement yoga interventional therapy as per developed protocol, to compare the client pre-test, post-test outcome difference in terms of blood pressure level, stress level, and quality of life between experimental and control group, and to find out the impact of yoga interventional therapy on blood pressure, stress, and quality of life of hypertensive clients, find out the association between blood pressure level, stress level, and quality of life of hypertensive clients with their selected demographic variables with and without yoga interventional therapy. So, can I skip, ma'am, operational definition?
No, but I cannot see the slides also. They are not moving. You have to push the button share screen. Then only we can see the moving. We haven't seen, you are stuck on first title slide.
No, ma'am, moving?
There is no slides on the screen now. Share screen.
Madam, good morning. Amandeep ma'am, just click share screen. A green button, just click there. There will be a green button, share screen, yes.
Yes, 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 yes. I already shared, but
No, it has been stopped. So again, you click the share screen.
Anyway, read the findings and
Yes,
the
sir.
implement.
okay, ma'am.
We can hear.
Okay, ma'am. Okay, ma'am.
Yeah, we can hear, but we cannot see any slide.
Okay. Ma'am. So only finding, ma'am. So first development of the tool. So tool divided into 4 parts. So first section A will deal with the socio-demographic profile. Section B with the blood pressure record performance. Section 3 perceived stress scale used to measure the stress level. And section D the World Health Organization quality of life BREF English version used to assess the quality of life of hypertensive clients. So the main development of the yoga therapy protocol. So a protocol for yoga intervention was developed. So yoga was demonstrated by trained therapist and me to the group of 25 subjects and consists of a set of 6 systematic yoga therapy demonstration. So the first subject was assigned in the experimental group and in the control group. So 100 in each group. So intervention group was divided into 4 smaller groups. So each group met daily for 1 month for 60 minutes at the healthcare center to practice yoga with the yoga is instruction and mind. So they were also given a yoga calendar in which to record which they did yoga. The yoga classes comprised various yoga movements, positions, breathing technique, and meditation. So especially the Anulom Vilom, Sukhasan, Savasan. So the subject daily did the yoga practice in the healthcare center. So collection of data. So first day the pre-test was taken, then the intervention given for 30 days to 25 subjects. And so 13 subjects were dropped from the experimental group, and then data was analyzed only for 87 subjects. So in the major findings related to the effectiveness of yoga therapy. So first in pre-test, experimental group, so in experimental group during the comparison of mean pre-test and post-test systolic blood pressure of experimental and control group. So in experimental group in pre-test, the mean was 145 and ST was 11.45. But after giving the yoga therapy in post-test, the mean was 138.8 and the standard deviation 9.56. So it means the yoga therapy had a positive impact to bring the to lower down the blood pressure, systolic blood pressure. Whereas in the control group, the mean was 145.26 in pre-test and ST was 9.73. And in post-test, the mean were also same, almost same, 144.24 and standard deviation 8.90. So this means there is no effect, there is no any change in the blood pressure of the subject in a control group. So then comparison of the mean pre-test and post-test diastolic blood pressure. So in the pre-test, the diastolic blood pressure in the experimental group was 86.11 and standard deviation was 6.64. But after giving the yoga therapy, the post-test that mean in the post-test 80.05 and standard deviation 4.60. So it means there was a positive impact of yoga therapy lowering the diastolic blood pressure. Whereas in control group, the mean was 85.92 and standard deviation 5.87. And but in post test, the mean also almost same. So there is no change in the diastolic blood pressure. So change in the pre-test and the post in the experimental group, so the blood pressure come down to minus 6.06, and in the control group minus 2. Okay. So it can be the effect of the due to the effect of the drugs. So stress level in the pre-test, the in experimental group, 40 subjects having a moderate stress and 47 subjects having a severe stress. But after giving the yoga therapy, the 52 subjects come into the minimal level and 35 subjects come into the mild level. But in the control group, there is no any change. So next is the quality, as per the quality of life. So during the pre-test in experimental group, 28 subjects having the average quality of life and 59 subjects having a good quality of life. But after giving the yoga therapy, so all the 87 subjects having a good quality of life. But in the control group, there is no any change. And so this means there is a positive impact of yoga therapy on to lowering the blood pressure and to lower the stress level and to improve the quality of life of the hypertensive clients. So as per the association, so there is a significant association of blood pressure with the family income and dietary habit at the post-test level. And post-test significance association of stress level with the educational status. So other variables found non-significant association. So implication in the different fields of the nursing. First of all, in nursing practice, so the nurses should have the skill providing holistic care to the hypertensive clients using yoga therapy, so as it lower blood pressure, reduce stress level, and improve the quality of life. So these study finding can be disseminated to use it as an alternative therapy in all the areas of medicine like pulmonary, psychiatry, oncology, dermatology, cardiac, geriatric, and for pain reduction. So the nurses and the health professionals recognize the benefit of yoga therapy and it is value in speeding up the recovery process of minor ailments and disorders. So it helps to improve the creativity of the nursing student. So we should teach the students also. So yoga therapy can be made accessible to all the patient in all ward in the hospital. So in nursing education, the nurse educator can provide in-service education to nursing personnel to update their knowledge about the alternative and complementary therapies of treatment like music therapy, yoga therapy, and it is valuable benefits to the patient's community. So the nurse educator can create awareness about the therapeutic benefits of yoga therapy by preparing the references which provide information about steps in yoga therapy, the therapeutic effects, and disseminating it to the clinicians of all the specialty and all the patient visiting the hospital. Nurse educator must highlight the importance of yoga therapy in modifying the biological and physiological pattern of hypertensive clients in their day-to-day practice. Nursing in the nursing administration. So the finding of the study helped to motivate the nurses to conduct research on yoga therapy in future. So nurse researcher must give importance to conduct more studies related to yoga therapy as a mean to reduce blood pressure, stress, and to improve the quality of life. And in nursing research, the nurse administrator should motivate the nurses and student nurses in implication of the yoga therapy. The nurse administrator should conduct in-service education of importance of yoga therapy and alternative therapy to disseminate the research finding through continuous nursing education to all nurses. So So conclusion of the study. So a short yoga program for patient to practice at home seem to have an anti-hypertensive effect. So as well as a positive effect on self-rated quality of life and reduction of stress. So this implies that simple yoga exercises may be useful as a supplementary blood pressure therapy in addition to the medical treatment. So when prescribed by primary care physician, and it also lowered the patient perception on stress and it enhanced the patient perception on health. So the one could also speculate as to whether these in long run could influence the medicine intake side effects and drug cost. So high blood pressure is influenced by the stress and strain of the modern lifestyle. So there is a wealth of clinical significant research that suggests adopting the yogic practices and principles can help to improve health and mental well-being, increasing resiliency to stress, and by extension to high blood pressure. So it may seem like stating the obvious, but if one reduces the stress on the mind and the body by eating healthy diet, focus on pure, wholesome, and nutritious food, so practicing yoga asanas, pranayama, and meditation, so the blood pressure can be controlled within the normal limits. So thank you very much.
Thank you again. Whatever it was, the end is so good that we can adopt yoga also. Lavanya ji, are you there to give a quick
Yes,
feedback?
ma'am. Yes, ma'am. I'm here. Thank you so much, Amandeep, ma'am. Though we couldn't see your slides, but we could capture what you were trying to tell us. Thank you for that. And as we know, there's an era of yoga, and everything can be cured by yoga and Ayurveda. So my question to you is, are you a yoga trainer? Have you taken a...
Yes, I have taken training from Rishikesh, 200 hours in yoga.
Great. So you got a certification for that.
Yes, I am certified yoga instructor, but I also taken the help of yoga instructor.
That's great.
During my study, so I also have taken the help.
You can continue even apart from your study now because you are a yoga trainer. You can continue with the social cause of teaching many more. They can manage their blood pressure and other conditions by doing yoga. It's nice. Many studies have come up in the nursing professionals also doing studies through yoga. That's a good move. But that need to be practiced in the clinical area, as Madam Bimla said in the morning. Whatever studies we do, let's take it to the practice. It shouldn't go in a paper, data, and in the journal and the publication. That's not the end of the studies. I think you should continue this cause, social cause, noble cause, in fact, preventing these kind of diseases. Thank you so much.
It's my routine in psychiatric ward. Every day, my students motivate them, especially my ward, only few patients with the mental illness. Most of the patients come for de-addiction. So my students daily do the yoga practices with the patient.
Great. Nice, ma'am. Thank you so much.
Wonderful. Thank you, Lavanya ji. Our Iron Lady, Professor Dr. Bimla ji.
It is something very important which goes without saying. It's not necessary only in the psychiatric ward. It can be OPD patients waiting. It can be antenatal mothers, postnatal mothers, So you can try to teach these kind of activities to everybody, because this is something you are trained for, So that's very fortunate that you are trained for and you can train your students. Without certification, at least they can give some kind of yoga exercises. Thank you so much. Good.
Thank you, ma'am.
Say the vote of thanks, but where is Binu sir? If you can put that, otherwise I will just fold my hands. Say thank you so much. Binu sir, are you there?
Yes, I'm here only, ma'am.
Okay, just put the last one so I can take the names also. The end part. After this, I find is after this. Yes. Okay, as we are nearing the end of the session, it is time to thank our dignitaries and presenters. Our sincere thanks to Professor Dr. Neerja Sood for honoring us with her gracious presence and blessings to the presenters. Thanks are due to our guest of honor, Professor Dr. Lavanya ji, who has played diligently the role of resource person by contributing valuable feedback. Our thanks to Evergreen special guest, Professor Dr. Bimla Kapoorji, and of course Ashish is not here, for your unconditional support by your graceful presence and interacting positively with these research presenters, and it is very encouraging to them, boosting their morale too. My personal sincere thanks to Professor Dr. Muttu for being MC and inviting respected guests. And our thanks to our National President, Professor Dr. Binu Jo, for providing uninterrupted Zoom link and with a powerful message as usual. Our thanks to entire organizing committee members, Kuntla ji and others. Last but not least, our thanks to all the presenters and lovely audience for their valuable time and their hard work in the research, then presenting, and we keep on interrupting them. Okay, take out methodology, take out this, take out that. But you can see still we are over time now, and there is a next meeting after this. So now we end here the formal recording. Time to say bye and thank you to everyone.
Thank you. Thank you, everyone. Thanks
Thank
a
you,
lot.
ma'am. Thank you.
Thank you.
Bye.
Thank you, ma'am. Thank you so much, everyone.
Yeah, thank you, everyone. Thank you, Binu sir.
Binu sir, one photo of everyone. If you can show on the board.
Yes, ma'am.
No, I thought we can take one photo before dispersing.
Okay, let me get ready with camera.
If everyone is here, I don't know if Bimla madam has gone.
Can you please, all of you can please switch on your cameras. So can we have a photo section?
Four of us, but there is somebody else too, Sudeep. He just got up. Oh, he is here. Anyway, how many are there? You can just take. Oh, Sir Salvarajan is there. Thank you, sir.
Thank you, ma'am.
Good night, all bye, and have a happy Easter. And we will go on to the other link to start the other meeting.
Yeah, madam. Now other meeting is another different link.
Sir,
Yeah,
do I
okay.
have to connect again? Or you can get us on this?
I'll try to coordinate, ma'am.
I think everyone can be excused.
Yeah, can we leave, Binu sir, now? Is it?
Please, yes, please, thank you so much.
Can we end the meeting, ma'am?
Yeah, but I see Subrata ji, so we are going on already. I don't want to stay.